remember from yesterday.
Very good. Well, as we're setting up, I want you to know this is Jackie Druin. I'm the president of the World Congress for Physical Therapy's International Physical Therapists for HIV/AIDS, Oncology, and Hospice and Palliative Care. And we have the very good fortune of having Clare Lait here with us today. Clare Lait has been instrumental in the Gloucestershire area in the United Kingdom and inspirational in developing oncology rehab programs that include physical as well as psychological care. She also has a specialty in head and neck cancers, and she works with breast cancers. She just received a Master's of Science in Clinical Cancer Care, and if you could expound upon that just a bit. But I wanted to also congratulate you for being awarded one of the pre-conferences at the World Congress for Physical Therapy on Cancer Care, and that's going to be in Geneva in May of next year. So that's a huge international accomplishment.
Thank you. Also thanks to Lou James, actually, in Australia. So I'll be presenting with her and a colleague of mine, Amanda Trickett, as well. So yeah, very exciting. So thank you.
Yeah, and I'm trying to register for that. I don't think they put the registration up yet, but I'm hoping to be there.
Fabulous. I could meet you in person.
That would be great. Okay, Clare, I'm going to let you take it away, and I'm going to silence my voice. But Clare has asked in our preview that if you have questions along the way, you can either ask her a question by using your audio portion, or you can use the chat line to type in a question, and we'll be monitoring the chat line during the presentation. Clare is really good at bouncing and managing a whole bunch of things. You know, you have that Twitter account where you can come in and make comments, and that's just been brilliant. So this is going to be really interesting. So I'll let you take it away then, Clare. Thank you.
Thank you, Jackie. Can you all see my screen? Can everyone see my screen okay?
Yes.
Yeah, perfect. Okay, so welcome. I'm going to talk to you today about kind of physiotherapy management, but really in the context of a community model that I've been a part of setting up and developing alongside some other allied health professional colleagues of mine. So my boss is a radiographer, and I work alongside the dietitian and also healthy lifestyle specialist. So we have one member of our team who is a personal trainer, another one who has a background in mindfulness practitioning. And we've got a couple of other colleagues as well that specialise in cancer as a background, who work to run a lot of our workshops. So my talk today is perhaps, when I first started being a physiotherapist, I always assumed that we were looking at the anatomy and the physiology, and I stuck very much by that. And my background is in musculoskeletal physiotherapy, but when I took on working within the cancer population, much the same as you guys, it really changed my view of what physiotherapy was and what we deliver, and how much more of the emotional and the mental health side of things that we encompass and we see with people with chronic illness such as cancer and the consequences. So my talk will talk probably more about the model that we have, because it's really opened my eyes, and I think it's something that can be used as a model across all conditions. I just have for Jackie wanted me to put a picture up. That's me, just to show show that I am here in my very thinking pose. And in terms of the overview of the presentation, what I want to do is look at the cancer landscape, and particularly talking about the cancer landscape in the UK, but I think that we're talking cancer landscape worldwide, the consequences of cancer itself and the treatments, the background to where our services come from, the actual model of care that our service delivers, some of the results, because we've been evaluating our service over the summer, and then our future developments going forward. If you want me to slow down or I'm going too fast, please do let me know, because I get quite passionate about this subject. So I want to make sure that you can hear everything I'm saying. So looking at the cancer landscape itself, here in the UK, we know that survival rates for people living with cancer are currently at about 2.8 million, and they're set to rise by 4 million by 2030. And what we've found is that the cancer population, because it's associated with an aging population, is that they're coming to us or presenting to us as physiotherapists and as health professionals with a lot of complexity, both physically and mentally. And the more that people survive as a result of aggressive treatments, we're seeing different presentations of consequences coming out. So a lot of my role has been around thinking outside the box where there aren't guidelines, particularly when you're looking at those who are living with their cancer, so the advanced cancers, those living with metastatic spread, and particularly in reference to getting these individuals active when their cancer and their treatments have stopped them from being able to do that, stopped them from being able to live their lives because of the many consequences, but then also stopped them from leading healthy lives, and as I say, particularly in reference to the physical activity. One of my roles in my current job is to lead on physical activity, in which I've done within Gloucestershire, and I've liaised with a number of cancer rehabilitation professionals, so particularly with a background in personal training, who have done the cancer rehab course that we have here in the UK, run by a lady called Anna Campbell. And these have been very influential in allowing us to do a stepped approach with rehabilitation. So for those with complexity who have got consequences that need specific physiotherapy, then we will see those on a one-to-one. And then what we do is work very closely with our personal trainers to then refer patients on so that they're actually getting active in their own community. They're getting the skills to be able to self-manage, keep themselves fit and active, and they know how to do that without our help going forward. So I think, you know, in terms of looking at the cancer landscape, years ago people would say, you know, you get a cancer diagnosis and that's it, and unfortunately you die. But what we're seeing now is that these individuals are not dying, they are living a lot longer, and that is going to rise. And talking to a psychology colleague of mine the other week, you know, we were both saying what we're seeing is a lot more complexity, particularly on the psychological side. So it's being very aware that, you know, we're still using our anatomical and our physiological skills, but we have to really look at, which I think we do inherently do as physiotherapists, but I've thought about it more and more working with these individuals, that the emotional side of what they're going through has a significant impact on their consequences. So in terms of looking at the evidence, our service is run in the community, and what the evidence shows is that a significant proportion of patients feel lost and abandoned by their healthcare system after their initial treatment has been completed. When they're in acute care and when they're in the hospital, they have people around them all the time, they've got appointments constantly, and then they suddenly get discharged home to their own community and they don't have that support and that backup of knowing that they're safe. And they're often left with many consequences and with an inability to regain their life that they once had. And an overwhelming fear of anxiety around the fact that their cancer may come back. So the fear of recurrence is huge, and we see that a lot in the literature from these individuals. And one of the things we have tried to do is make sure, through national policies and through the Macmillan charity that we're funded by, is that we're supporting these individuals once they've gone through their treatments to be able to pick their lives back up and know if there is a problem that they can easily re-access the service, particularly with regards to the acute care. So we know that from the evidence that exercise, diet and positive psychology can have a huge impact on health outcomes and well-being. But often people struggle to know what to do to help them get back and healthy. A lot of them are deconditioned and they don't really know what's happened to their body. They don't really understand what's happened, and they often feel very isolated, like they're the only individual going through this experience. So it can be a very, very lonely place for these individuals. So our service was co-created by patients and stakeholders and our team to try and fill these gaps, particularly in Gloucestershire, to support patients to self-manage, particularly in the areas of diet, activity, and also the positive psychology, so managing those fears and anxieties. So looking at the consequences particularly, there are a huge number of consequences, but the biggest ones that we see are people's fatigue rate. So we know that 80% of the population of those who've had a cancer diagnosis will struggle with fatigue, which stops them from being able to be active, stops them from getting their life back, and in a number of individuals stops them from being able to go back to work. But for some, once they're back in work, they actually struggle to retain themselves in work. Pain is a significant barrier to people also being able to move on with their lives, and it in itself can create issues with depression and anxiety. And pain as physiotherapists is something that we really focus on. 95% of the people that come through my door in clinic have a pain, and their immediate thought is that the cancer has returned. And one of the lovely things about being a physiotherapist, particularly for me having worked in a musculoskeletal background, is that I can look at that pain, I can assess them, and I can say, well, actually, this is a result of radiotherapy, or this is from your scar, or actually, no, we do need to get people back and we need to get them checked. And it's an amazing feeling being able to reassure people on both fronts that, you know, they are not making it up, which is what a lot of people think, that when they report a pain, they're going to feel or be told that actually they've made it up. But also, if they have thought that it's a cancer coming back, being able to reassure them that this is an effective treatment can allow them to just reduce that anxiety and that fear again. Anxiety and depression and stress or distress is another key area that comes up as part of Macmillan's package of care, which is called the recovery package for anyone that wants to, if you Google recovery package. What patients are offered is what's called a holistic needs assessment, and I'm not sure how worldwide that is or people's knowledge of it, but it's a fantastic tool that actually picks up, based on the current research and what patients report are their primary problems, and it lists the physical, emotional, the financial, the spiritual concerns that people with cancer have reported in the past. And it asks patients to report on a scale of 0 to 10, which are their most important concerns. And one of the things about this document is that as healthcare professionals, we want to fix. And we often hear the first or second concern that comes out of somebody's mouth, but actually it might not be their primary concern. And what the concerns tool does is it allows that patient to reflect on the concerns that they have and really draw out what is the most important concern to them. And I think as healthcare professionals, we have an agenda in some respects, because we know that someone's been referred to us for a particular pain or something else. And actually, what I've learned over this time is that might not be what they're worried about. What they're worried about is what their relative is thinking, or how their relationship with their partner, and that's perhaps driving some of their intensity of their pain and their inability to move on. And actually, by addressing that problem that seems almost totally interrelated, totally unrelated, actually resolves some of the issues that they've got. So one of the ways that it was explained to me, which I just thought was absolutely brilliant, was that moment that we all know we get, where you do your assessment, you do the treatment, and then the patient walks out the door, holds onto the door handle and turns around and says, oh, I just wanted to talk to you about the one thing. It's probably the most important thing that they needed to talk to you about. And the holistic needs assessment tool actually stops that from happening. So it's a brilliant tool if you know, in terms of if people wanted to look at a tool to actually utilize. But as part of that, the tool then allows us to look at what those top concerns are nationally. So there's a national database that collects those concerns and then allows services such as ours to develop different programs that make sure we're addressing those concerns. So the fatigue, the pain, the anxiety, the worry and the fear come up really, really high with these individuals. And then the sleepless nights also comes into that. And we know that if people are struggling with sleep, that's going to significantly affect their ability to heal, both mentally and physically. Due to the production of a particular hormone such as ghrelin, which stops people feeling like it encourages that hunger, and the hormone leptin is actually inhibited. So the hormone leptin stops us from feeling full. So if we're not getting enough sleep, then we're going to put on weight. We know with cancer treatment, particularly with your breast and your prostate cancers where they're on hormones, they do put on a lot of weight as a result of deconditioning, but as a result of hormones and as a result of chemotherapy and the steroids. And that's then fueled by sleepless nights that can be a result of hot flushes, which also can be improved by sleep. So the sleep and the activity and the diet are absolutely crucial, and that's one of the things as a service we try and do, is look at those 4 pillars of health. And then I put on the other circle is that, who are they? They have a huge loss of identity, and that can fuel, again, the fatigue, the pain, the anxiety, and the sleepless nights. In actually establishing, once you've been through a cancer diagnosis and you've been through treatment, actually who they want to be, because they often struggle to get back their former life and their former identity. And for a number of individuals, if you look at the head and neck cancer population, particularly in the male population, for a number of individuals due to shoulder dysfunction, they can't get back to manual work, and that can cause a huge loss of identity. So we do a lot of work around actually looking at people's values and their priorities and what they want out of life. And one of the workshops I was running today, we look very much at that. And for some people, they have a cancer diagnosis. It's a life-threatening diagnosis, and cancer is the most feared word for so many. And it puts things into perspective. And for a number of people, looking at life as very stressful, working all the time, not doing enough activity, not perhaps eating the right things, not doing relaxation, people look at their life and they think, well, actually, I don't want to be like that anymore. I want to change. So sometimes it can be a positive thing. One of the things we try and do is we work very much around evidence-based and level A evidence. And that's very much what drives our programs, and also we run some education programs for healthcare professionals. But educating patients about the importance of being active, particularly when you're looking at disease progression and mortality rates, is absolutely huge. And from the evidence, we know that by doing 2.5 hours of moderate intensity activity for breast cancer patients lowers mortality and disease progression by 40%. With prostate cancer, doing 3 hours of vigorous intensity lowers mortality by 30% and disease progression by 57%. And we're particularly talking about an advanced cancer population. And in the colorectal cancer population, although it's slightly more in 6 hours, is a huge lower in mortality rates of 50%, and same with disease progression. So one of the things that happens again with the consequences of treatment is that people lose motivation. And these statistics are huge for motivating both healthcare professionals to have conversations around, actually it's really important to be active, and we can refer you on to physiotherapists who can support you, and personal trainers support you in managing those consequences that prevent you from being active, but also direct you using FIT principle, correct movement and core as to what's safe for you and what's ideal in your circumstances, so it becomes individualized. But these statistics, I think, are huge, and they're really powerful, particularly for healthcare professionals who a lot of them don't really know, and a lot of them are responsible for referring into our service, and I think that's the case, worldwide. And if it's not even on their radar, then trying to get referrals through is very, very difficult. So looking at the mortality rates, these are the specific or the big ones that we look at, that rehabilitation cuts the risk of developing other health conditions. So we know that a cancer is associated with an aging population who will come with comorbidities, such as cardiovascular disease and stroke and diabetes. But we also know that cancer treatments create comorbidities. So in a breast cancer population, for some, chemotherapies can create cardiotoxic events. And in our situation, for a number of these individuals, this is 4 years post-treatment and sometimes at 10 years post-treatment. So we have to be hypervigilant and we have to educate patients that actually some of them will have a heightened risk. So from my experience, what I've done is advise patients to just regularly take their blood pressure and just be aware of any particular cardiac issues that might present themselves. So if you're looking at a younger lady, for example, who suddenly develops a level of fatigue that isn't normal for her, then you would perhaps think, what's going on from a cardiac perspective, and perhaps get them to be checked out. And what we've seen within our service, we regularly check blood pressure before people become active. And we've actually referred a number of patients back because their blood pressure has been too high. And for some individuals, the physical activity element of it actually doesn't mitigate that high hypertension. There are 9 different cardiovascular dysfunctions that people can present with as a result of cancer treatment, and hypertension is one of them. So it's important that we look and we work alongside GPs and physicians to make sure that for those individuals where physical activity isn't going to mitigate the effects, that actually they are looking at that medication. The stroke and the diabetes is also very important to alleviate. And then at the bottom of the slide, what I've made sure that we consider is those mental health issues, particularly that anxiety and that depression. We know that people with cancer are twice as likely to commit suicide as opposed to the general population. And this is often related to pain and an inability to work. So it's really important that actually we are aware that these things happen, because they're not something that are easily talked about for a number of people. And in this population, and I guess in all populations, we find that sex, death, and emotional health is something that's not commonly shared unless we as health professionals ask, is this the problem? How are you getting on? You know, do you want to talk about that? And the physical side of things is very tangible, and it's very easy, I feel, in our roles to actually bring people in, start getting them active, talk about their consequences, and then they start to build up trust, and then they open up. And if you've got an awareness that there might be something going on, it's much easier for those individuals to open up and to trust us. So looking at our service, what we provide is, our service is called Macmillan Next Steps Cancer Rehabilitation, and we are funded by Macmillan, or we have been funded over the last 3 years to provide this recovery and rehabilitation for people when they need us most. So we can see people pre-treatment. It's not a big thing at the minute, but I know it is nationally on our agenda. And I believe worldwide it is out there, and is really important for preventing a lot of those long-term consequences. So primarily at the minute, what we do is we provide that recovery and rehabilitation and advice after someone has finished that active treatment, or if someone is living with their cancer. What we try and do is we change the focus from cancer to the individual on health and well-being. So what we see historically is a medical model, and what we are trying to do is change that focus and say, actually, you know, diagnosis is searching for the cancer cells, treatment is focused on eradicating those cancer cells. And so the emphasis on recovery and self-management and healthy lifestyle has historically been lost. So what we are trying to do with our service and with our education is actually get out that message that there is a person and a family that is underneath all of this, who actually we need to support them with their health and well-being. And the wider determinants of health are much, much greater than just that medical model. So we work on the principle of the 4 pillars of health. So the importance of educating on relaxation, on eating well, on sleeping and activity. And what we also recognize is that people feeling isolated, and not just geographically and environmentally, but isolated in their feelings of, I'm the only person going through this experience, is detrimental to someone's health. So connecting them together in the workshops that we run or the programs that we run actually allows them to feel more positive about themselves and helps their health outcomes, because they're connecting with others and they can share their thoughts and their deepest feelings, and they know that actually those people that they're with truly understand what they're going through. So our actual program follows a three-step model. So we have recovery programs, which is our allied health professionals. So myself as a physiotherapist and my colleague, who's also a physiotherapist, and we have a dietitian, and we work very, very closely together. So we've run joint clinics in the past where actually, again, as a physiotherapist, I've thought, oh, we need to get this person active. And if they've got colorectal cancer and their bowels are all over the place and they are so embarrassed they don't want to go out, I'm not going to get anywhere. So what we have to do is actually look at their dietary habits and get their diet sorted and their weight, and then we can look at their activity. And also on that front, if you've got someone who's malnutritioned, there's no way I'm going to get them active, because actually they haven't got the energy levels to do that. So working alongside a dietitian enables those conversations, and I've learned an enormous amount at widening my skill set to actually appreciate, actually as allied health professionals, the skill sets that we have and how we can work so well together. And then we have a prevent program, so we have group activities, which we have a 6-week physical activity program that's run by our personal trainer, and my colleague physiotherapist inputs into that. And we wrote that together 2 years ago. And we've tried different models of care. We tried doing the 6-week program, which was structured to being, they had to attend every week. And what we found was that didn't work, because the people that were coming through our service were generally people going back to work, and it didn't work. So what we did was a rolling program where people can drop in, but it works now, and we've got a number of people coming through the service each week, of about 15 a week. My dietitian colleague and our therapy assistant, who has a background working with OTs and physios, run what's called a Recipe for Health program, which is a 4-week program looking at healthy eating and also combining that with activity. And that is a fantastic program for actually showing that you can't just do physical activity on its own, and you can't just do dietetics on its own. You have to do the two together. And then we run positive psychology workshops. So these are primarily written by Macmillan and Coventry University. One of them is called the HOPE program, which you may have seen on Twitter, and a Take Control, which is a 3-hour workshop which looks at fatigue, fear and anxiety, diet, activity, and sleep. And the HOPE program elaborates more to look at sex, intimacy, body image, communication, fear of recurrence, and uncertainty into the future. And what we then do is we sustain that. So we signpost individuals on. So if we have someone with high complexity psychologically, we refer them on to the psychologist. If we've got someone who's got financial worries, we can refer them on to our financial support. And we also have liaised with our community sector to ensure that from an activity point of view, there is something out there in the community for these individuals that is safe and is run by knowledgeable personal trainers, which are also trained by the Cancer Rehab program that's run. And we have within Gloucestershire voluntary sectors, charitable sectors, where again people can drop in, they can get involved in the art programs, they can get involved in music, and again looking at that wider determinants of health. So this is our service, which you can see is quite comprehensive. We try to make sure, if you look at 12 o'clock, people come to our Take Control workshop that gives them the basics of what they can take away with them, and for a number of individuals that's all they need. And then for others, they want to go on and do HOPE or the Recipe for Health or the other programs that we run. We also have what's called a Time and Space, which is a program run specifically for carers. And that works really, really well for, again, those individuals also need our support. On the right-hand side, I've got the 4 or 5 pillars of health. And on the left-hand side, all our programs are underpinned by patient activation. So we use a patient activation measure which looks at patients on 4 levels. So your 1s and 2s are individuals who won't be able to go out and find the support that they need. They need to be advised, they need to be supported, they need to be facilitated in knowing what will help them the most. And your level 3s and 4s will be people that are more activated. No matter what, they will go out there and they will find the resources that will help them because they're at that activation level. And what we try as a service is to take people up a level or as high a level as we can, and we've demonstrated through our evaluation that we've been able to do that by giving the people the skills, the knowledge to be able to self-manage their own condition in their community. And what our evaluation showed was that people who come through our service are more activated, more knowledgeable, and they don't need to come back, and they have actually voiced that they don't feel that they need to come back because they feel they know now what to do if something was to go wrong or if they were struggling. They've got those strategies and those tools. We also underpin everything with motivational interviewing and coaching, and we are all facilitators within our workshops to ensure that people's needs are being heard appropriately. So to date, we have helped over the last 2 years nearly, or probably over now, 800 patients and probably about 60 carers. And we have trained over 4,000 healthcare professionals, particularly in looking at those discussions of managing healthcare professionals. Of having those conversations around healthy lifestyles. One of the things that I found when I was doing my master's that Jackie talked about, which was the clinical leadership in cancer, palliative care and end of life. For my dissertation, I looked at the barriers to people being active, particularly following a breast cancer population. And one of the biggest areas was healthcare professionals not actually advising people to be active. So a number of individuals wanted to be active, but they didn't know that they could, and they didn't know that it was safe, and they didn't know that it would be beneficial. So one of the I guess, driving forces behind our educational programs has been that, and being able to say to individuals, this is your role, this is everybody's role. It doesn't matter whether you are a healthcare assistant, whether you're a nurse, whether you're a doctor. Actually, every individual should be having these conversations because it's what patients want. And the same applies with diet, and the same applies with anxiety. And actually asking a patient, how did it make you feel, having a cancer diagnosis and going through treatment, is incredible for actually empowering an individual and showing them that you're listening. And by you listening, they open up and they trust you. So with regard to our evaluation, we have had external evaluation through the University of Gloucestershire, and we have looked at qualitative feedback from patients through our questionnaires, but also through asking patient stories. And we've also looked at the quantitative measures, so looking at cardiovascular fitness, looking at strength, looking at central adiposity, looking at fatigue. So these were some of the quotes that came back from patients about how they felt that the service had helped. And this we do quite a few in terms of wordles, again, bringing in words that patients have felt have helped. And one of the things I like as a physiotherapist, that exercise comes up hugely on this. And we know that exercise has incredibly powerful effects on mental well-being and physical. What I'm going to do is just read to you a little excerpt from a patient who came through our service, because I think it says more than I could probably say to you in a presentation about what the service actually offers. And I think I would extend this beyond our service and say this is what cancer rehabilitation, this is what our role as physiotherapists, as allied health professionals does for patients. So I'm going to just read this to you. I welcome this opportunity to tell you about the fantastic support and outstanding service I have had from Macmillan Next Steps. Put simply, they have given me my life back and helped me grab the second chance I have been given. I am now fitter, healthier, both physically and importantly mentally, than I think I have ever been. A chance conversation put me in contact with the Next Steps team, the start of what has been a fantastic journey through a wide range of their courses. I have got to know the team who's facilitated the courses brilliantly. All courses complement each other well, providing supportive, relaxed, open environment to really explore issues and talk to people who really understand. There were tears, but mostly there was laughter and the feeling of really safe environment where you could truly be yourself. They didn't shy away from difficult subjects or sugarcoat things. They challenged us all. They made time to get to know us and our motivations and background. They demonstrated a real love and interest in what they were doing. I have now lost 16.5 pounds, 10 centimetres around my waist, and increased my strength and cardiovascular fitness significantly. I feel so much better. The fatigue has gone. I have more energy and I'm better able to cope with stress. And importantly, I have made some great friends. So what I've done is I've put on the slide some of our outcomes that we have seen. So in terms of looking at cardiovascular fitness, what we've seen within all of our groups, so our breast, our colorectal and our prostate, is a huge improvement that is sustained over those three. So this is looked at from the very beginning and then at 3 months. So we're seeing sustainable changes once people have left our service and gone out to the community. And similarly in the strength, looking at sit to stand, we've also seen a significant improvement. And what's been really lovely is that we've also seen significant improvements in patients who are living with advanced cancers, where a number of them have had no support, they've had no advice, and actually what we've done is change their lives. They're living with their cancer, but they're now stronger, they're more independent, and they're able to actually do things that make them happy, which they couldn't do before. One of the other things I touched on, the ability for our participants to be able to move forward with their lives, but also looking at fatigue. And we know that 80% of the population struggle with fatigue, and it can significantly affect their ability to move on. And what we saw through our programs is a significant drop in fatigue that normalized to that of healthy levels. So people felt that actually they were able to carry out the things that they wanted to. And we know from research that without rehabilitation, some people will bring their fatigue levels back, but a number of people struggle with fatigue on a longer basis that can affect their longer term health. Patient activation, which I touched on, increased by 19.2%, with patients increasing to a level, which means that they are managing their condition much, much better. And there were meaningful improvements, both mentally and physically, to individuals. I talked about our colleagues' education, and my dietetic colleague and I specifically ran what we called supper and learn events, where we were talking around having these healthy conversations. And what we saw was at the beginning of these sessions, people didn't raise the issue of physical activity. And by the end, people were raising this 76 to 100%. And the same was true of weight. And again, we asked the question why this was, and there were a lot of people that were saying, well, we're opening a can of worms, we don't have the time, this is not our role. And by the time we'd given them the statistics, we looked at behaviour change, we had given them permission within their roles to have these conversations, and then to refer on to our service where we could support these individuals better with structured programs that were prescribed and individualized to them. They were much more confident to open up that conversation. And therefore what we saw was a greater increase in our referral rates, which then meant more people were able to get the support, the help that they needed. And that we see across the UK, one of the biggest problems with activity programs and again with rehabilitation is actually getting the bottoms on the seats. And I don't know again whether that's a worldwide problem as well. And that was drilled down to actually giving those healthcare professionals the skills and the knowledge to know where to refer them on to. And the same applied with stress and anxiety. And again, actually, for a number of individuals, they did discuss it. But there was still a number who weren't discussing it at all. And then if we look at where our future developments are as a cancer rehabilitation service, our biggest thing is we are waiting to hear whether we get recommissioned. So our services are often pump prime funded by Macmillan to set the service up, develop as a project, and then demonstrate that we're seeing improvement. And then the NHS will or will not commission that service so that it becomes a service in its own right. So that we're awaiting that decision currently, and hopefully then that means from March the service will be recommissioned so it can continue on. Because what we're seeing is that there are a number of other services across the UK who are setting up similar models. So it's really important to continue that community of practice and share ideas, but also keep that ball rolling with cancer rehabilitation to show that allied health professionals and physiotherapists have a huge role to play in actually preventing ill health, but helping with those consequences to prevent people using expensive and costly resources, being on antidepressants, being on painkillers, when actually we can sort a lot of that out with our hands and with our mouths and communication. We recently did a sleep training course, so we're looking to develop and roll out sleep training because we know that that comes up very highly for individuals. We want to run, and we've got funding to run more of our supper and learns and having those healthy conversations. We have a conference that's I developed and led the preparation for, that's going to be run in February, that looks at managing the psychosexual issues of post-radiotherapy for pelvic disease. We're going to continue to collaborate with the acute sector, so we are in the middle of running workshops for individuals with the nursing colleagues, and that's the plan, is to run that out more, because I think the interlinkage between acute and community sector is not so great where we are, and that needs to happen more and more to get a smoother pathway. Establishing further carers course is also on the agenda, and then looking at succession planning in relation to exercise professionals. So we have a group of exercise professionals who are absolutely superb, and we have a brilliant model that runs, but going forward we're going to have an increased demand. And we need to make sure we've got more capacity, and we are making sure that succession planning, so that when those individuals do move on, if they move on, we have a new cohort of individuals who can carry this great work on. We currently support people with breast, colorectal and prostate cancer, but the wish, I guess, would be to roll out to all cancer groups. My background within cancer has been with all cancer groups, but taking on this project meant that we had to focus on those three. And then what would be great to be able to demonstrate a longer term evaluation. So currently in the UK, and I believe worldwide, there are not economic figures attached to cancer rehabilitation. And in order to get more services funded, we need to be able to demonstrate that we are having a economic benefit to individuals, to organisations, and to society as a whole. So now that we've got some great short-term figures from an evaluation point of view, it would be great to be able to complete a longer-term evaluation to be able to demonstrate that, so that more of these services can be available for a greater number of individuals across the UK and worldwide. So that is me in a nutshell and our service, and I hope that I've given you some insight into what we do, and perhaps given you some things to think about. Or, you know, as I've spoken to people before, reassured people that actually we're all doing similar things, and I guess facing the same challenges when it comes to setting up services and trying to put our heads above the parapet and say cancer rehabilitation is really, really important. And we have cardiac rehabilitation that sits up there as a great model, but maybe cancer rehabilitation is not seen in the same light yet, but has the potential, if we keep driving it forward, to do so in the same way.
All right, thank you, Claire. This was wonderful. It's amazing to hear how comprehensive your program is. What I'd like to do now is open up the floor for further questions. Okay. And people can use the chat line, or they can use their microphones. Well, I seem to have a lot of feedback here. So I'm going to turn mine off.
So for those of you that are listening, is there anything that kind of resonates or with yourselves around establishing cancer rehabilitation? Has anyone faced any challenges or any concerns about doing that?
Hi, Claire, can you hear me?
Yeah, I can.
Oh, great. I just realized I was speaking and I couldn't quite connect, but now I just unmuted myself, so that's a good thing. Firstly, I want to thank you for your wonderful presentation, and secondarily, I want to inquire about a little bit of the health policy and accreditation process. I serve as the APPA's representative on the Commission on Cancer for Accreditation.
Yes.
And I have been very fortunate to make a breakthrough in not having rehabilitation as a nice-to-have referral, but now as an essential standard.
Brilliant. Okay.
Have you found that is part of your health system that has it as a standard versus a nice-to-have service?
No. Well, it's one of those that so Macmillan have produced this recovery package, which we have national policies that have recommended that by 2020, 2021, everybody should have access to a recovery package. But that doesn't stipulate cancer rehabilitation within that. So it has been a problem in trying to get out there what cancer rehabilitation actually is. And one of the things in the recovery package is it talks about health and wellbeing events, which we run as part of it. But what we've found is probably 80% of the people that come on those health and wellbeing events need rehabilitation to some extent. And I guess that's, our service has been leading the way in the UK with that, of actually demonstrating that there is a need for this cancer rehabilitation. And one of the things we hope is that we get commissioned so that we can get that message out there more widely, to perhaps get that, more, something as a standard rather than this is a lovely thing to have. It's all seen as that icing on the cake, which is what you're saying, unfortunately.
Yeah, I think that seat at the table makes a huge difference, and it's taken many years for us to even get to this point.
Yeah.
And it's been a real work in progress for an entire year on the accreditation side of revamp for our COC. And I wish the same for you, because I know that when it becomes a standard, a different storyline comes into play, simply because they must check the box that we are triggering an appropriate rehabilitation referral at points along the trajectory of survivorship. So I wish you well in that.
Thank you. And we have a number of guidelines that have been written, but again, they're guidelines, so they don't have to be, adhered to. And I think that's the real shame, in that, there's been a lot of work that's been done around actually saying that this is a really, really important area. But unfortunately, a lot of it comes down to funding, and to have rehabilitation specialists can be seen as expensive. But we've got something in the UK that's called AHPs into Action, which has been really, being driven at the minute quite hard around looking at the benefit that allied health professionals have on cost savings. And that's where, I feel very passionately about trying to get that message out there, that what we do, it might look expensive at the forefront, but actually we are saving an enormous amount, beyond that. But it's having the insight or the foresight to see that.
Absolutely. Well, thank you for all your great work.
Oh, but thank you.
If no one has another question, may I interject again?
Yeah, of course.
Okay, great. So I'm just curious, do you happen to have an algorithm for your psychosexual issues that you triage earlier, and how does that clinical pathway play out?
For the psychosexual issues?
Yes.
We don't at the minute, and that's partly why I did organised the conference for February, because what basically happened was a patient had pelvic radiotherapy and was really struggling, and she could not get access to anybody. We have no psychological services to help these individuals. There's no psychosexual support, and so one of the things that they did was they formed a working group to look from a radiotherapy point of view, physiotherapy, the patient was included in this, to say, well, actually, you know, what's going on and why are we not supporting these individuals? Because these are huge issues that are not brought up at all. And so I spoke to a lady called Dr. Isabel White, who is a leading specialist in this area in London. And I said to her, you know, how would we go about putting together a conference to try and see whether we can educate staff and then, you know, potentially off the back of that, look at the services that need to be put in place. And she said to me, what you need to do is you need to talk about the bladder and the bowel, and you need to be actually incorporating that into, say, an algorithm, but incorporating that into a conference, because without discussing those, then you can't even get to the psychosexual issues. So the conference is very much, I guess, a kind of opening up a knowledge base for individuals to then potentially look at what services. But currently in Gloucestershire, there is nothing for these individuals.
Wow. Okay. Thank you.
Hi, Claire. I have a question, or some comments, actually.
Yeah.
Starting out, is there too much feedback for people to understand me?
I can just about hear you.
Okay. Does somebody have a telephone on that might be affecting this? Okay, let's try again. So I'm very impressed with your comprehensive approach. In where my area is, we have pockets of people who go to physical therapy.
Yeah.
But not everybody even gets to go to physical therapy, like Mary Lou was saying.
Yeah.
But I love how you have a structured, organized, evaluated program, and you have specific access to care.
Yeah.
And also, you're following the PTs to see who's asking patients whether they have a problem.
Yeah.
And the PTs I work with are also in line with what your colleague said about bowel and bladder care.
Yeah.
That PTs aren't typically even asking whether people are having issues there. And we need to ask the question to open the door.
Absolutely. And I think it's, you know, it's a huge taboo subject that so many people are uncomfortable with. You know, anything to do with bladder, bowel, sex, and as I say, death, it doesn't get mentioned. And I think from a PT point of view, having that confidence to say, actually, just ask, because you'd be surprised that actually even just showing that you care, even if you can't help, you can refer on. I mean, I'm not a women's health specialist or men's health specialist by background, but we have resources from, you know, from a bladder and bowel point of view that we can refer on to, which are very, very good. But actually just having the space for that individual to discuss these areas is huge for them, because people don't talk about it at home either.
One comment. I have a student right now who's looking into breast cancer patients and their association with higher rates of thyroid disease.
Yep.
Yep, you've heard that? You know that?
Yeah. Yeah. Yeah, I mean, one of the things that I found that if anyone's had radiotherapy, particularly to that area, then they are much higher risk of thyroid issues.
She's doing a case study in one of my classes. Her name's Virginia Peer. And she's also found, and you probably are aware of it, that if they have thyroid conditions, they also have more issues with joints, like adhesive capsulitis.
Yeah, yeah. And also, like any of the, I mean, I've been amazed at, you know, in terms of all the hormone treatments that people are on, and the predisposition to ligament and tendon issues. And you've also got a population, I guess, when I worked privately, I attracted a lot of the younger population who were desperate to get back to sport, and they'd go back to sport and then get injured straight away because they just weren't ready. And you'd say to them, well, look, do you know what? You've got a higher risk of tendon or ligament injuries because of the emotional stuff that's been going on from a cancer diagnosis and treatment, but also because of the hormones that you're on. They will, we will make that worse. But yeah, no, the thyroid is a big one actually, and I think, and the parathyroid as well, I think is also, again, not really looked into in a number of areas.
Yeah, because that contributes to fatigue with so many of these patients too.
Yeah, absolutely, definitely. Yep. And the sleep was something we were fascinated by, and looking at when people go through chemotherapy, their circadian rhythm flattens. So where you normally have, peaks and troughs in your circadian rhythm, when you go through that chemotherapy, you're then getting little dips and rises. You don't get that normal pattern. So that massively interferes with your ability to sleep and then therefore to recover. And that must, in some senses, have an impact on someone's fatigue levels and their rates. So we were quite blown away by little things like that you think, wow. And actually for a patient being able to say, look, this is physiologically what happens to you when you go through your treatment. It allows them an explanation as to why they feel so utterly dreadful.
Right. Well, are there any more questions?
Can I have a question very quickly?
Yes.
Thank you, Claire. I'm a professor in South Korea. Currently, I am visiting scholar in the Clare University in the city. I'm a repeat specialist. I have a very short question. As a manual drainage therapist, I always interested in the intensity of physical activity.
Yep.
You said the prostate cancer, vigorous intense activity can lower the multilateral progression, right?
Yep.
Yeah, but as you know, once the swelling occurs, it is impossible to return to normal. Therefore, it is very difficult to determine the exercise intensity. So I want to know how to determine the intensity of your exercise, and if you see the edema, what do you do?
How do we determine whether they're doing moderate or vigorous?
Right.
Is that your question?
Right.
So what we would describe to them is, when they're doing moderate, then they're able to have a conversation, but in terms of the vigorous or the brisk, then they're not able to have that conversation. They are doing whatever activity it is to a level where they can't speak. Does that answer your question?
Yes, if you see the edema or the lymphedema, after that, how can you adjust the intensity of physical activity?
So if they've got lymphedema,
yes.
I think we would still. I'm not a lymphedema specialist, but we would still keep someone, like if they had a lymphedema in their arm, we would say that they need to use their sleeve, but we wouldn't. I don't think we would change that intensity from a strength component. We would, again, I would encourage people to do strength work, but to do it in a progressive, trained perspective. So not just try and go and lift stuff when they've never lifted stuff before, but actually doing gentle weights and then not sustaining that weight. So I think from an intensity cardiovascular point of view, I would still do the vigorous or the moderate.
Okay. Thank you.
Would that be something do you tend to advise on activity?
Pardon?
When you see lymphedema patients, do you tend to advise on cardiovascular stuff or not?
Yes. If there is a lymphedema, I can consider many things to intensity or the duration. Or, as you said, the cardiovascular problem like this. So, in my experience, it's not easy to determine the intensity or determine the method of the physical activity. So that's why I ask you.
So the other thing we do tend to use is use the rate of perceived exertion. Have you ever used that? So we get them that correlates with heart rate. So we get them to say, well, this is where you need to be on your rate of perceived exertion, and then we get them to do the activity and say where they think they are, and actually then if they're going too hard, then we get them to drop back, but if they're not going hard enough, then we get them to push on a little bit more. So that gives us that probably actually is better as a measure than being slightly out of breath, because that then gives you that guidance if they're going too hard. And then from a lymphedema perspective, I think if you've got like lower lymphedema, I would very much be getting them to monitor that lymphedema and see where they're going if the intensity is too hard. So yeah, actually I see more where you're coming from. Okay, so yeah, so I think that the rate of perceived exertion would be something I would recommend. You can get the rate of perceived exertion or the modified one, and that will give you a correlation of how hard they're working associated with their heart rate. So have you ever used that one?
Okay, thank you.
Have I answered your question?
Yes.
Yeah.
Thank you very much.
But I know what you mean. It is very, very difficult, and I think with people with lymphedema, they've got to self-monitor very, very carefully, and not over push it. Same with like seromas. Saying if people need to be very careful about what they do so they don't overdo it, and that can be quite tricky.
That's right.
All right.
All right. If there are no further questions, I'm sure Claire would be available to take questions through an email.
Yeah, absolutely.
Could you give your email, Claire?
Yeah, oh, sorry, I should have written it on the slide there. It's Clare, which is CLARE, and then it's .LAIT at cancer, then a -physio.com. But you can find me on Twitter as well. I'm under Clare Lait Physio.
And very exciting under Clare Lait Physio.
Yeah. But be aware, you might be bombarded by pictures of my children.
And that's a good thing, too. But I just wanted to thank you again and congratulate you for presenting for our group. Nina Shekbo from Nigeria was also on this for a while, and she's our education director.
Brilliant.
So she will be sending you an International Scholar Award from the IPT-HOPE group network right now. And yeah, so we'd like to recognize your wonderful work.
Thank you.
Yeah, of course. And we're hoping in Geneva that we can be accepted from being a network to a subgroup. So if you keep your fingers crossed, we're working hard on that.
Oh, definitely. Oh, well, I can't wait. I'd love to meet you. It would be fabulous.
Yes, yes.
And Jackie, if there's anything else that I can do to help, please do let me know. I'm more than happy. I'm incredibly passionate about this area. So
thank you.
Just let me know.
And the same thing with us and our network. If there's anything we can do to promote all the fine work you're doing. Just let us know.
Thank you.
Okay, well, thank you again.
All right, thank you.
Yep, and we'll be signing off now. What I'll be doing is putting the recording up on the website so that people who weren't able to attend it in real time because it's nighttime or because of work issues will be able to do your presentation.
Okay,
so,
fabulous.
Thanks again. Great talking to you.
My pleasure. And you take care. Thank you.
Thank you. Bye-bye.
Bye.